on the subject of making changes through collaboration. I'll base my talk on the journey and accomplishment of the Australian and New Zealand Neonatal Network. Neonatal intensive care is expensive, can be complex issues, depends on the parents' wish, what they want. Is that feasible? What is the responsibility for the clinician? And more importantly, what's the prospect of acceptable short-term and long-term outcomes? Of course, there's a lot of ethical and practical problems for the parents and clinician. Sick baby cannot survive without intensive care and can be at high risk of death or serious morbidity if intensive care is provided. My PhD student published recently a systematic review and meta-analysis of the survival of the extremely preterm infants. In this study, we look at 217 studies involving almost a million babies who were born at 28 weeks gestation or earlier from year 2000 to June 2024. We look at the survivals. As you can see on the left, survival rate continued to increase with increasing gestation. And the survival without major morbidity is quite low and also increased a bit more faster with increasing gestation. Overall, 61% survived to discharge and 51% discharged without major morbidities. There are outcome disparities. Of course, publications are dominated by high-income countries. They also report higher survival rate. In high-income countries, 69% survive. 55% from upper middle-income countries, 34% from lower middle income, and 32% from low-income countries. Over time, the survival rate had improved, as you can see from the left, with gestation age on the x-axis. But interesting observation, among the low and middle income countries, survival improved at a faster pace, from 38% to 45% in the later years. With very little changes in the high-income countries, the improvement mainly in the 24-25 weeks gestation survivals. Benchmarking is important. Valid data is important. Identifying best practice and how to implement those best practices are most important, leading to improved standard of care and outcomes. Sometimes we're not just benchmarking outcome alone with numbers. We need to measure the processes and outcome trends. A simple example here, washing hands as a process and lead to a reduction in infection rates. You can see many outcomes improve not based on just resources or funding. It's often a better adherence to best practices. When talking about best practice, we often talk about the level of evidence. High quality of evidence comes from large collaborative randomized trials of high quality or the meta-analysis of high quality trials. Very commonly, everybody agrees that what they read about what is the best practice, But why there is a variation in outcomes? A typical example of delay cord clamping in preterm infants. Major study come from Australia and New Zealand. Delay cord clamping saved lives. Published in New England Journal of Medicine 2017. Last trials, 1,500 baby less than 30 weeks. We also conduct a high-quality meta-analysis to confirm these findings. They're published in American Journal of Obstetrics and Gynecology as labeled as a report of high impact in 2018. But what really happened in Australia is New Zealand. Our network monitored the uptake trend of delay cord clamping for less than 32 weeks gestation over the 4 years after the New England Journal publication. Over these 4 years, delay cord clamping mostly occurred in about 50% of infants born. And in fact, only one unit reached the benchmark of 85% by 2021. Why? Can we make sure that it happens all the time, at the right time, and at the right place? That is the question. With this finding, we actually got fortunate to have funding to run an implementation trial, so-called WAM trial, wait a minute or more, a pragmatic step-wise cluster randomized trial. In this trial, all the participant center go through a process of self-evaluation, obtaining buy-in for stakeholders, confirmed to a uniform QI methodology. In fact, that is the EPIC training that our network endorsed in 2019. Important to have regular local QI team meetings. We have dashboard feedback for all participating hospitals and involvement of consumers in the trial. Bottom line, local team collaboration is crucial for success. We hope this trial will be successful and that we're able to inform us how to conduct optimized quality improvement projects. It's actually a change in culture. Going back to our network, we start off in a humble way. This is the first report in 1994, 30 years ago. At that time, we only collect minimal data from less than 32 weeks gestation, on less than 1,500 grams, based at Sydney University. 22 out of the 29 NICU had participated. In fact, the report contained only 2,700 babies. We look at the mission, characteristics, and outcome of major adverse events, mortality, and major morbidities. Well, the current home of our network is still in Sydney, now based at the University of New South Wales, where I work, at the Centre of Big Data in Health Research. In this journey, after we moved, we established the Data Collection Operation Committee, reviewed the structure and formalized all the data items, governance, adding more data items with a clear and consistent definition, meaningful, interpretable, clinically relevant. And we have to collect all those data through human resource ethics approval using opt-out consent. We also established a follow-up committee to report neurodevelopmental outcome of all baby less than 29 weeks until 2009 at the age of 2 to 3 years of age. A standardized assessment define outcome of cerebral palsy, blindness, deafness, cognitive impairment. What do we do now? It's still a self-funded organization from members and sponsors based on common minimal data set, although increasing. We monitor outcome, adopting and promoting best practice, facilitating research, benchmarking with other populations. In fact, we participate in the national network, the annual collaboration in comparing outcomes. We are now more than 34 NICU or NICU in Australia and New Zealand, and the national member from Singapore and Hong Kong had joined. We also have the high dependency special care units. And total now we have over 11,000 babies meet and add to our data set every year. Long-term outcome of over 1,000 high-risk babies were born before 28 weeks. We also established the data collection for the surgical network and the retrieval network, so all the data can be linked from birth to long-term outcomes. Traditionally, this is the way we often in old time to look at benchmarking. This is a typical caterpillar plot ranking performance. But we quickly recognize the performance fluctuate from year to year. It depends on the number of very hard, tiny babies, varying risk every year. The size of NICU also different. So we move on to another benchmarking about adjusting for case mix respectors and also sample size. This is just what we call the funnel plot as shown here. The variation of the NICU size and case mix are adjusted. On the x-axis, the expected number of cases, and on the y-axis is a standardized ratio adjusted to risk factors and sample size. 1 equal to expected performance based on the average risk in the network. And there's a 95% confidence interval illustrated in here. Our philosophy is to showcase the better performers, so we identify by ID in this graph. This allows collaborative learning in discussion and comparison of different implementation practices, why some units do better, even agreeing on the same principle. Neurological outcome, the mental outcome is also looked at, also adjust for gestation, gender, and birth weight. It's always a balance between mortality and long-term outcome. More baby die, but you might have better long-term outcome. Or you have low mortality and higher rate of impairment. We also produce so-called a quarterly feedback report. So every 3 months, for example, in here, late onset sepsis rate. In here, the observed rate in red dot, you can see it can fluctuate every 3 months. And the blue line is the expected rate based on the risk, and the red line is exponentially weighted moving average, and it is very easy to see this unit was started with close to average and continue to improve, and now better than an average baby admitted in the NICU in Australia and our network with a lower infection rate. We also provide a forum for collaborative learning. We start our annual conference. Different to others, that we don't just have people to give internet expert opinion and lecture us, but we also have focused breakout sessions, groups to discuss on PPD, infection, golden hour, nutrition, surgery, and discussion of evidence-based practice, how to implement and what are the obstacles. The key point is participation of all members, sharing experience about implementation, about learning from each other. We also have methodology training workshop to how to conduct quality improvement projects. As you have saw before, the well-performing unit identified in our benchmarking presentations. And the top 5 are often invited to present and discuss the unit clinical practice, why they can achieve better outcome, overcoming obstacles, and then sharing the knowledge and implementation of the evidence-based practice. Well, what are the outcomes? It's a quick snapshot on the trend of severe IVH, and that was published in arXiv. So we look at 3 epochs from very early 1995 until 2012. As you can see in the table in here on the left, the reduction of severe IVH or death or composite adverse outcome. Severe IVH dropped from 6.6% to 5.7% to 5%. Mortality rate dropped from 10 to 9 and to 7.8. And the composite outcome of death or severe IVH from 14 to 12 to 10%, almost 1/3 lower. And on the graph below, we can see the increasing trend of survival and survival without severe IVH. That was published in arXiv in 2018. More recent time, we look at IVH rate compared to countries in the INO network. And the graph you can see the major IVH, grade 3 and 4 by gestational age, 22-23 weeks, 24-25 weeks, 26-27, and 28-29 weeks. Australia and New Zealand rank quite high. They compare with Australia, New Zealand, Canada, Israel, Japan, which has the lowest, Sweden, Switzerland, UK, Finland, and Tuscany, and we rank second. In summary, Australia and New Zealand network compare favorably to international comparisons. We We can learn from each other as well as from our international counterpart, not just benchmarking, ranking alone. Collaboration is important in clinical practice improvement. Clinical research is vitally important to provide the best evidence for practice to improve outcomes. Finally, it's our responsibility to provide best care without long-term harm to our patients. Thank you for your attention.